Now it is my pleasure to introduce my co-chairman, Professor Thomas van Gulik from Amsterdam Medical Center, who is going to talk about preoperative preparation of the patients with perihilar cholangiocarcinoma instead of Professor Yu Man-Fong from USA.
Thank you very much, American ladies and gentlemen. Again, it's a great pleasure to take part in this postgraduate course. I must say it is, for me, very helpful, and I've learned many things listening to all the presentations of this morning. So my assignment was to speak about preoperative preparation and the liver resection for perihilar cholangiocarcinoma. But because this Friday at 11 o'clock I will have a talk about surgical management of perihilar cholangiocarcinoma, I thought I would limit this presentation only to the preoperative part, to preoperative diagnosis and preparation, because that is key, I think, in doing a successful resection for cholangiocarcinoma. So please bear with me, and I hope you will be here. I know most of you will stay on Friday to hear the typical surgical part of this topic. Now, this morning I noticed that when the presenters were talking about perihilar cholangiocarcinoma, they were talking about Klatskin tumors. So I think what we first need to sort out is the terminology of this type of tumor. We know that these tumors arise typically at the confluence of the left and the right hepatic ducts, and in fact it was Mr. Klatskin who in 1965 defined this tumor as a nodular tumor arising at the hilum of the liver, and I think he was more a pathologist than a surgeon, but anyway, that tumor continued to carry his name. But I think that it is better to talk about a perihilar cholangiocarcinoma, indicating those tumors which arise at the confluence of the left and right hepatic ducts. But it is a difficult definition because, as Hauke Lang already pointed out, if you have an intrahepatic cholangiocarcinoma which encroaches on the liver hilum, then you will have a biliary obstruction, and usually those tumors are larger than the real Klatskin tumors, but they are in the same way managed as a perihilar carcinoma. So there is a gray area in your definition of perihilar intrahepatic carcinoma, but I think perihilar carcinoma is the best way to indicate these tumors. Well, the spectrum has been described this morning. Hauke has talked about the intrahepatic tumors, and when we look at the extrahepatic bile ducts, the tumors arising at the hepatic hilum are the most frequent, as you see here, 70%. But there is some 20 to 30% which arise in the distal bile duct. And of course, that requires a totally different management, because when you have a distal bile duct carcinoma, the treatment is the same as for a pancreatic head tumor. You would do a Whipple's resection. So the target organ is the pancreas. Whereas when you have a perihilar cholangiocarcinoma, especially when you have these type 4, and most of the tumors we see are type 4, 3A or 3Bs, they extend into the segmental bile ducts, and they require an extended liver resection. So in these patients, the target organ is the liver. And I think that's the difference between, let's say, the treatment of those two entities, which I will further point out when we're talking about the preparation for the patients with this tumor. And sometimes you have these type of perihilar cholangiocarcinomas which extend along the bile ducts into the part of the bile duct which resides in the pancreas. And then you have to do a combination of a liver resection and a pancreatoduodenectomy, and that is called an hepatopancreatoduodenectomy. Those are, of course, extensive operations where you do your liver resection, your complete livenectomy, and your pancreatoduodenectomy to complete the resection. And of course, there's also a morbidity rate you have to take into account. But there are favorable theories from Japan indicating that this is a viable option. Well, having said this, I just wanted to emphasize how important it is that as HPB surgeons, we are able to work on the liver side as well as the pancreatic side. Having been in this business for some years now, I see that there's a slight diversion into doctors doing, surgeons doing hepatobiliary surgery and surgeons doing pancreatic surgery, and they seem to go apart. And that's, I think, a bad way to go for our community. So I would like to advise all of you just to have a broad, let's say, participation in the full scope of HPB surgery, that you're able to do a hepatic resection and you're able to do a duodenectomy, so that when you're doing a liver resection for perihilar carcinoma, you can do the duodenectomy yourself. So that is just an advice to the community from my own perspective. Now, what are the issues in the surgical treatment of cholangiocarcinoma in general, but especially for perihilar carcinoma? Those are the things I would like to discuss with you. The preoperative diagnosis is extremely important, especially the differentiation between benign and malignant lesions. And then the selection of patients who you deem resectable is another point which you have to rely on your diagnostic modalities. And then after you've done your diagnostic phase, you're in the phase in which you want to prepare the patients for these large resections in order to improve your outcomes. So then we're talking about the optimization of your future remnant liver, which includes preoperative biliary drainage or not. And that is a large discussion. Then the extent of resection is also a point. But I think I would like to concentrate on the preparation of these patients in order that they are as most as possible fit for these large resections. So this slide shows our experience in our center, in the AMC in Amsterdam, and as you see that when you look at the denominator of patients, and I think it's very important, you see when you read publications, they say, well, we operated X number of patients, but it is very difficult to extract how many patients they see in one center. So the denominator of patients is, I think, very important to take into account, also to show what kind of a center you are. So there were 600 patients who were referred to our center on the suspicion of a perihilar cholangiocarcinoma. As you see, about 1/3 are declined for resection because of obvious locally advanced disease or metastasis. So that leaves you with 2/3 who might be resectable. We use diagnostic laparoscopy, and I'll tell you about declining, let's say, value of using diagnostic laparoscopy, but we still do that in selected cases. And then some 300 go on to laparotomy, of which 2/3 are resected because the other 1/3 appear to have on your exploration metastasis or other signs of advanced disease, which precludes a R0 resection. So in the end, about 1/3 of those 600 patients are resected, and of those 200 patients, not all have a proven malignancy, but there are some 50% who appear to have a benign lesion in spite of all the diagnostics we did, and all those patients were resected on suspicion of a perihilar carcinoma. Now, I would like to focus on our experience with diagnostic laparoscopy, but also on this category of patients who do not appear to have a malignancy and who are exposed to this high-risk surgery for which they actually didn't need that part of surgery. And if you know that in the Western centers, the mortality, I'll tell you about that on Friday, still is, with extended resections, around 10%. And if you look at the series carefully, it is still 10%. Then you should really think about exposing these patients to that high-risk surgery when they actually don't need that. So the dilemma is when you have a patient with a stricture at the liver hilum, is it malignant or benign? And the first speaker, our radiology colleague, already touched upon that problem of defining a malignant lesion and differentiating it from a benign lesion. But that is one of the most important points, I think, and very difficult to show. So what are the cholangiopathies we see? Well, there are several, but for surgeons, I think these are the most important. You want to know, of course, the malignant ones, but we also deal with the iatrogenic bile duct strictures. We have been speaking about that this morning, and about the strictures we see in primary sclerosing cholangitis. So these are for, let's say, for our practice, the most important. But then, more in recent years, we have seen this type of IgG4 associated cholangitis appearing now as an entity. And the first speaker this morning already alluded to that syndrome. So I'd like to take a few moments with you to talk about that, because it's so important to recognize that, because those patients are treated very well on steroid therapy. Well, these are examples of patients in whom we did a resection on the suspicion of a perihilar cholangiocarcinoma, but these were all benign lesions, except for this lesion, which was a gallbladder carcinoma, which also can mimic a malignancy at the hepatic hilum. So what is the usual algorithm, or what's the usual scheme for diagnosis of these patients? Clinical presentation is important. They usually come with painless jaundice and weight loss. Laboratory tests are limited value, but the CA-99 is, I think, an important point. However, when you have a patient who is jaundiced, CA-99 is unreliable because it is elevated because of the cholestasis. There's a whole range of imaging studies you can use. I'll come back to that later. But mostly we have a cytology result from our ERCPs or from the PTCDs done in which cells are retrieved for microscopical examination. But the cytology results are notoriously unreliable with a sensitivity of only 50 to 60%. EUS, I think, has a potential, and there are reports which show a very high sensitivity, but that is very operator dependent, and I think that it is difficult to use that systematically in patients with a hilar cholangiocarcinoma. Now, we have a large experience with the treatment of these patients, and at several time points, we have actually assessed the number of the rate of patients who had a benign lesion instead of the presumed carcinoma. And when you look at the whole literature, you see that it is between 8% and 24%. In our series, at several time points, we defined the same percentage of 13, 50%, and 15% of false positive results of these hilar tumors. So you could ask yourself, well, haven't we got any better in all these years in spite of improved imaging techniques, etc., etc.? Well, actually, we did not, and we still have 15% of benign lesions in these tumors. The Japanese are doing better. They see a rate of, let's say, benign lesions in that region, 5% instead of 15% or more reported in the West. And probably that is because they much more use, let's say, cholangioscopy and spyglass techniques to actually visualize the tumor and to do intraluminal biopsy of the tumor. So I think that is the way to go to decrease that rate of false positive diagnosis. So anyway, just realize that many of the patients we operate with the suspicion of a perihilar carcinoma, we have no tissue diagnosis. In our case, it's 50% of the patients who have no proof of malignancy. A medical oncologist will never do that. A medical oncologist will always want to have a cytological or histological proof of the tumor before he will start with chemotherapy. Imagine we operate half of those patients without a diagnosis. But that is real life. I think in most centers we cannot operate only those patients in which we have a pathological proof of the tumor. So that means that in 10 or 50% of the cases, the stricture turns out to be a benign lesion. And as I said, 35% of these patients in our case have this type of IgG4-related cholangitis, which is characterized by this plasma cellular infiltration on histology. Now, just to focus on this disease, it is a multi-systemic disease. It is known as salivary glands in the retroperitoneal cavity, and more recently we have identified this cholangitis in the pancreas, which was called in the beginning autoimmune pancreatitis, and it is the same entity we encounter in the biliary tract. So we should be aware that about 1/3 of those patients with a benign lesion have this type of IgG4-associated cholangitis, and as I said, they respond very well to steroid therapy, and usually you have to keep them on steroid therapy, but that is the way you see treatment. So how can we identify those patients with IgG4-associated cholangitis? Well, you can measure in the plasma IgG4 levels, plasma levels, but that is not very reliable because 20% of patients with a hilar cholangiocarcinoma also have an IgG4 elevated level in their blood. So that is a problem. One of the things we have developed in our center is a qPCR test which can detect the fraction of total IgG4 mRNA that encodes for IgG4, and that is a more, let's say, accurate way of detecting the disease. And as you see in these graphs, we are able, with this diagnostic test, to discriminate patients with IgG4-related disease from patients with PSC and a carcinoma. And when you have patients with this IgG4-related cholangitis, you can also use this parameter for assessment of your therapy. So when you respond to therapy, the plasma level goes down. So I think that is an invaluable, let's say, adjunct to our diagnosis. So when we look at those patients who we think are potentially resectable, we have to decide on what we think is resectable, what are the criteria for resectability or unresectability. Well, when there are extrahepatic metastases, I think we all agree that those patients are not will not benefit from a larger resection. It is a question if they have intrahepatic metastases on the contralateral or unilateral side, what to do. But if there has extrahepatic metastasis, I think that it has no benefit. Lymph node metastasis is an area of discussion. When they are confined to the hepatoduodenal ligament, so the N1 nodes, we always do resection with a complete lymphadenectomy, of course. But when they extend into the region of the common hepatic artery and the celiac axis, when you have those N2 nodes, the literature is controversial, but we do not think that those patients really benefit from a large resection. Actually, in our experience, those patients do not well. So when there is an N2 positive lymph node, we don't do a resection. Of course, the single most important parameter is achieving an R0 resection, so you have to see that on your preoperative imaging that you're able to do a R0 section, of course, with frozen sections of your section margin during the operation. Involvement of portal vein bifurcation, when that happens, then you should be prepared to excise, of course, the portal vein bifurcation, so that is not a contraindication. But when there is involvement of the hepatic artery branch to the part of the liver you want to preserve, and usually that is the right anterior posterior branch of the hepatic artery in a patient in which you want to do an extended left, I think that is a problem because when you lose the artery, you will lose the patient. And the Nagoya series, of course, show very good results of microsurgical reconstruction of those arteries. But I think in our, let's say, practice, that still is a high-risk procedure. Actually, that is for us a reason to decline a resection. And then the part of the liver that you want to preserve, the volume is, of course, important. I'll talk about that more about Friday, how important it is, but I'll just touch upon that in the next slides. So you can have imaging studies, you have your criteria for resectability, you will do your volume assessment for your future rectum and liver, staging laparoscopy, and preoperative biliary drainage. I think that is, those are the issues which we should discuss. Imaging studies. We've heard a lot about MRI this morning, but there are only little, let's say, solid studies about MRI in detection of PHC. Most of the studies involve CT assessment, and when you look at the CT results, you see that there's quite a high accuracy of a CT scan to detect vascular involvement and metastasis. When you want to look at the ductal extent, the use of CT scan is also better than with MRI, although now with the improved techniques of MRI, that is one thing we should look further into, especially when you do very detailed MRCs. But let's say that we still rely very much on the CT scan to map the tumor and to define our surgical strategy. Then the classification of the tumor and the staging is a point of discussion. Just want to say a few words about that. We usually look at the proximal extent of the tumor, to the Bismuth-Corlett classification, because it defines what kind of resection you should do, but that is only a surgical classification method which helps us to define the type of resection we want to do, but it doesn't tell you anything about vascular involvement, it doesn't tell you anything about possible lymph nodes. Now, the Bloomgard system, which was developed in Sloan Kettering, is, I think, a little outdated now because our possibilities for resection have increased, so I don't think this is very much more applicable. We have the TNM stage in AGC 7th edition. Those are post-hoc classifications, so more based on pathology. And in Zurich, there is a classification system developed, which might be useful, but it's quite elaborate to continue, and we have to see out from the registry what comes out. But what we, as surgeons, would look at in the first place is anti-Bismuth-Corlett classification. Now, that classification is based on the proximal extent of the tumor. Most of the tumors extend into the segmental bile ducts on the right side, 3A, on the left side, 3B, and when there is bilateral segmental involvement, it would be a type 4. Now, in most textbooks and reports, it says that when you have a type 4 tumor, that is not a resectable tumor. I don't know why, but in many reports, it is still considered unresectable if you have a type 4 tumor which extends into the segmental ducts on both sides. I think that very much depends on your hilar biliary anatomy, because, for instance, we know that 80% of patients have not one right hepatic duct, but they have a right posterior and right anterior duct, which drain directly in the bifurcation So if you have a tumor which extends into these segmental ducts, it can be classified as 3A, but in fact, it is not the 3A you would expect when you have a situation like this. So, for instance, in this patient, with this kind of trifurcation, in which the posterior and anterior duct would arise in a confluence, and you would have here segmental infiltration, the radiologist will say, well, that is both sides segmental infiltration, type 4, and the gastroenterologist might not even bother to refer that patient because in his textbooks it says they are not resectable. But of course, this patient is resectable because if you do a left resection with excision of the tumor, you could do a radical resection with a reconstruction of both ducts. And the same at the left side when you have involvement on the right side and you have a low takeoff of your segment 4 duct with infiltration. The radiologist will say it's a type 4 tumor, but of course, with your standard extended right hepatectomy, you can do an R0 resection, taking away that part of the segment 4 duct. So, I think it is extremely important to realize that resectability of these tumors depends on their biliary anatomy at the liver hilum, and that is why these patients should be considered in specialized centers where there are experienced hepatobiliary surgeons and gastroenterologists who know how to take care of these patients. And the Netherlands is not a very large country, 70 million, but there are 4 centers which specialize in this disease, and I think, personally, that is enough. Now, what is the role of staging laparoscopy? The idea is that with your laparoscopy, you define these small metastases on the diaphragm or on the contralateral side, which precludes a resection. Now, we've been doing that routinely for some years, but we've seen that let's say the yield is coming down. We've done this systematic review recently, and actually we showed that the yield has come down with your laparoscopy because of your improved imaging techniques, and it depends also on the year in which the study has been performed, because before we had those techniques, the yield was higher, but on average, the pooled yield is 24%, so that means that 1 out of 4 patients will benefit from a diagnostic staging laparoscopy in terms of a difference in management. So when you look at our series, up to 2000 it was 40%, but it has come down to 15%, and so in that paper which we wrote, is it still worthwhile? I think only in selected patients, and we have a kind of risk score developed in which patients with a tumor larger than 4 centimeters, suspicion on lymph node metastasis, arterial involvement, portal vein involvement, those are the patients which might benefit from a staging laparoscopy. So not routinely, but only selective. And what we also do with our staging laparoscopy is that we sample the lymph nodes along the common hepatic artery onto the celiac axis, because if we find positive nodes there, we will not resect those patients. So that's, I think, an additional benefit of doing a staging laparoscopy. Now, it is very difficult to decide on the basis of your diagnostic modalities which patients will be resectable at laparotomy and which patients probably have unresectable disease on laparotomy. We have a close collaboration with Memorial Sloan Kettering, and we pooled all our patients together. We analyzed 566 patients, of whom 309 underwent a curative in-stent resection, 26% had distant metastasis, and 18.4% had locally advanced disease. And when we analyzed, let's say, the preoperative predictors for resectability, we found that the jaundice, suspicion of lymph node metastasis, extent of bile duct involvement, suspected portal vein, and hepatic artery involvement were significant preoperative factors. So then you can define points, you can assign points to several conditions which you might detect. So when you have a patient with jaundice, it at 1 point, or when you have a patient with extensive proximal infiltration, 4 points, etc. And then when you add up all the points, you can make a kind of risk score to define those patients who probably have unresectable disease. So that means that when you have a patient with 10 points, that you know that the chance of a curative resection goes down and the finding of distant metastasis or local advanced disease goes up. So this helps you to define those patients who will probably have a resectable disease or not. So then the other point, the liver, the future remnant liver, how are we going to assess that? Now we always look at velometry of the liver. The question always is, how much do we need? You can do a standardized analysis, or you can look at the body weight ratio, but the problem always is how much do we need? And especially in patients with perihilar cholangiocarcinoma, that is, I think, a problem. Just look at a, let's say, absolute volumetric parameter as derived from CT volumetry. Because when you have a volume of the liver, we know that it depends on the quality, how much liver you would like to preserve. And these patients with perihilar carcinoma, they all have cholestasis, as in patients with cirrhosis. We know we need at least 40% of viable liver tissue. So I think that's one of the important things we should realize, that we need more remnant liver volume than, for instance, in a patient with liver metastasis with a principally normal parenchyma. Now, the last part I would like to discuss with you preoperative biliary drainage, because that is, I think, one of the most debated issues we have in these patients with perihilar carcinoma. There are 3 questions. Do we really need it? And when we need it, are we going to do that endoscopically or endoscopic via the nasobiliary drainage technique, which they are now, let's say, favoring in Japan, or should we do that by the percutaneous approach, doing a PT-BD? Well, those issues are, I think, around for the last 10 years that I've been in this business. Well, I think it is important to realize that when you have a distal biliary carcinoma, it is a different thing than a proximal biliary carcinoma. We've done a randomized controlled trial in patients with pancreatic head tumors who had a distal obstruction, and we saw that there let's say, the benefits of relief of jaundice didn't outweigh the complications of your bile duct instrumentation. So those patients had cholangitis and much more complications of the biliary drainage that did not benefit, of course, the relief of jaundice. So the conclusion of this New England Journal of Medicine study was, in patients with jaundice because of a pancreatic head tumor in which you do a Whipple's resection, you should do an immediate resection and should not do preoperative biliary drainage. I think for a perihilar carcinoma, there is a totally different ballgame, because in these patients you need to do a large liver resection and you rely on your regenerative capacity of your liver, of your remnant liver, on your postoperative outcomes. So in these patients, I think that the benefits of drainage outweigh the disadvantages of bile duct instrumentation and cholangitis. So we still think that in these patients with perihilar carcinoma who require a large liver resection, that they really need preoperative biliary drainage. But that depends on liver volume, and that's something I'm going to tell you about on Friday, how important it is to define the relation between the obstructed biliary system and your volume of remnant liver tissue. Now, when you look at the literature What are the pros? Do we really need it? Or preoperative biliary drainage for patients with PHC? Well, you treat segmental cholangitis, you have an improved regeneration of your remnant liver, you have a definition because you visualize the bile ducts of the proximal infiltration of the tumor, and it has been shown that when you do a drainage with your cholangiographies, you can increase the resectability rate. So what are the cons? There is a risk of thrombosis, hemophilia, there's an increased risk of cholangitis, which you actually induce because of your drainage, infectious complications. Cholangitis is, I think, one of the most important drawbacks of doing a resection. And there's also concerns regarding tumor cell seeding, seeding metastasis along the catheter tract, which has been reported to be 5 to 10%. Now, just to show you how important the volume of the liver is, this is a study from the French group by Olivier Farge, in which they pooled the data of 11 centers amounting to 180 patients, and those 11 centers were all specialized centers in the treatment of bile duct carcinoma. And when you look at the results, and you look at those patients who needed a right hepatectomy or a left hepatectomy, obviously the right hepatectomy had the smallest livers. When you look at those patients who were drained or not drained, the difference in the mortality and the outcome, when the patients were not drained, the mortality was 22%. Imagine 1 out of 5 patients dies, whereas if they were drained, it was 9%, which is about the average. However, when you look at the left hepatectomies, which leaves a larger amount of future remnant liver, you see that there is not so much difference, because when you look at the patients who had a drainage, it was 10%, and in those patients who had no drainage, it was less, but it was not statistically significant. But this actually suggests that in patients with a large remnant liver, you don't need drainage. So, do we really need it? Yes, we need it on the side of the liver you want to preserve, so you don't want to do bilateral drainage, and you have to do that when your FRL is less than 50%. So then the question arises, should you do that endoscopically or percutaneously? So endoscopically by ESCP or endonasobiliary drainage, or PTCBD by the interventional radiologists. We see more cholangitis after endoscopic drainage, more technical failures, and there's a quite large proportion of patients who have to be converted from PTBD, from EBD to PTBD. They have to be switched. As surgeons, we always like the percutaneous approach because we can use these drains to actually approach those tumors, and also to use the drains to drain the hepatico-jejunostomy. But what are the pros and the cons? Pros, the internal drainage of the bile to the gut. No percutaneous, it's more patient-friendly. And the con is the need for a sphincterotomy, the risk of cholangitis, and acute pancreatitis, which occurs in 10% about of the patients, and which sometimes means that the patient cannot be resected. Percutaneous drainage, the pros are the possibility of multiple segments. You have an external and an internal drainage, depends on if you internalize the drain, and it gives you, let's say, a very reliable cholangiography of the extent of tumor invasion, but it is an invasive procedure. There is risk of vascular complications, thrombosis, something we see, and tumor cells seeding along the catheter tract, which has been reported. Well, I don't think that is a argument not to do PTPD, because that is something which has been reported in the Japanese series, but we actually, in the Western series, haven't seen that so much. And in the same analysis with Sloan Kettering in New York, we looked at 234 patients who had EBD or PTBD. We looked at the incidence of seeding metastasis, actually found it in 3%, but there was no difference between EBDD or percutaneous drainage. And when you look at the survival, there was no difference in survival rate of patients who had a percutaneous or endoscopic drainage. So I don't think that is a valid argument anymore. And as I said, that as surgeons, we like the PTBDs because we can use the tracts, the drains, to when you shorten it and leave it across the hepatico-jejunal anastomosis, it gives you access to the anastomosis. So when there's a leakage, you can detect it and you can drain it by opening up that drain. But the literature is controversial. There are pros and there's pros for PTBD and EBD or indifference. So it's very difficult to decide, all retrospective studies, what is the best way, EBD or PTBD. So in the Netherlands, we decided to do a randomized trial. You know, we are very good in randomized trial in the Netherlands because we are a small country, we all know each other. And so it's possible to do a trial as complex as this in this setting. So that was a drainage trial, and we randomized patients into endoscopic drainage or percutaneous drainage, and we looked at the endpoints, drainage-related complications. There were 4 centers, all specialized in the treatment of perihilar cholangiocarcinoma. You can't do that with more centers because you need expert endoscopists and expert interventional radiologists, and we looked at the outcomes as you see here. So we randomized at one point 54 patients, 27 had EBD and 27 had PTBD. Please note that of those 27 patients who had the EBD, that 15 had to be switched to PTBD. So they crossed over, but because of the intention to treat analysis, they stayed in the EBD group. But when you look at the results halfway, because that was halfway the study, there was an appalling complication rate, mortality rate in those patients who had PTBD. 41%, 3 died before laparotomy. You never hear about those patients in reports about resection because they don't even reach the point of resection, whereas in the EBD group it was only 7%. And at that point, the Data Safety Monitoring Board forced us to stop that trial because of the large rate of mortality complications in the PTBD group. So that was a big surprise for us. How is it possible that these patients did so bad? Well, in conclusion, I think the most important points I would like to give you is that when we operate these patients, we have to realize that 10-15% don't have actually cancer, and a proportion might have this IgG4-mediated cholangitis, just to be aware of. The accuracy of imaging studies is about 60 to 90%, probably can improve with MRI. The staging systems we use mostly is still the Bismuth-Colette classification, and when we look at those patients, we should realize that resectability has to take into account the biliary anatomy and its variations at the liver hilum in order to be able to realize if you can do an R0 resection. The volume of the future remnant liver is important, 40%. Otherwise, consider portal vein embolization. When you look at the series from the Far East, they do much more portal vein embolization than we do in the West. So I think we need to have a more liberal use of portal vein embolization, and the yield of staging laparoscopy has decreased and should only be used in selected patients. And in conclusion, about preoperative biliary drainage in these patients, so I think the need for unilateral drainage depends on the volume of the future remnant liver. But if you have a patient with cholangitis, then drainage is mandatory, because one of the worst things that can happen is a patient with cholangitis. Endoscopic biliary drainage is associated with higher rates of conversion to percutaneous. The risk of CD metastasis is not increased after percutaneous PTBD. And PTBD was associated with a much higher rate of complications with endoscopic treatment, which came out of that drainage trial, which we presented at the E-AHPBA Congress in Mainz. And therefore, we advocate EBD as the initial method for preoperative biliary drainage. So I'm afraid that was quite a lot of information, not so much about resection, but please bear me, and I hope we can further discuss this on Friday. Thank you very much.